Hello and welcome to Single Payer Radio. I'm Paul Hoppe, broadcasting from the Habron Building in Louisville on the WFMP 106.5 Forward Radio Community Network. Our programs air every Monday at 2 p.m., Tuesday at 7 a.m., and Wednesday at 11 a.m. And we also stream our show on SoundCloud. The show is a project of Kentuckians for Single Payer Healthcare in conjunction with Physicians for a National Health Program through its Kentucky chapter. We produce this program because we believe healthcare is a human right. We advocate for a national, not-for-profit, publicly funded, single-payer healthcare system for everyone. The views and opinions expressed on our show are those of the speakers and not the station. Today I have Doctors Mike Flynn and Jean Shively in the studio with me, and they have a special guest, and the topic is going to be pain addiction management. And Mike will do the introductions. Mike?
Thank you, Paul. Let me begin with the usual disclaimer. First of all, it's Michael Flynn, retired surgical oncologist from the University of Louisville. Any comments I make during this program represent my personal views and do not represent the views of the University of Louisville or the Department of Surgery. Gene?
I'm Eugene Shively. I'm a retired general surgeon in rural Kentucky, Campbellsville, Kentucky. My comments do not represent Taylor Regional Hospital or the University of Louisville Department of Surgery.
Well, our topic today, as Paul indicated, will be drug use issues, pain management, and addiction. We have a special guest today who has expertise in these matters, James Patrick Murphy. He was an MD and an MMM, a Master of Medical Management. Got his medical degree at the University of Louisville, was an intern at the Naval Hospital in San Diego, flight surgeon. He did his residency in University of Louisville anesthesia, pain medicine fellowship at the Mayo Clinic, his combined board certification in pain management and addiction medicine. And he has a Master of Medical Management from the University of Southern California Marshall School of Business. And he is the medical director of the Murphy Pain Center in New Albany. Pat and I have a long history of connection with the Navy. We were in a reserve unit many years ago together. Pat, welcome to the program. We're looking forward to hearing your comments. As we have done in the past, we're going to give you an opportunity to make whatever comments you'd like to make for as long as you'd like to make them. And then Jean will begin the conversations with the first question. So, Pat, the floor is yours.
Thank you so much for that kind introduction, and I really appreciate the opportunity to be here. And I think, as we all know, this is a big issue because a day doesn't go by where the subject of addiction or the overdose crisis or the opioid crisis is not on the front pages or somebody's not talking about it. And it's really a big deal. And there's another issue going on as well that's kind of connected. That's also pain management. And in many respects, there's some crossover, but they're also two separate issues. And I think if we understand both, not only where they intersect, but also how they are different and how we need to address both issues, I think we can come to some understanding of how to get out of this problem that we're in. And that's why I'm glad to be here. So I just want to start out by saying that when we think of addiction, the thing we have to understand is that addiction is not a moral issue. It's not something that is well understood even by doctors. But we do know is that there are real changes that occur in the brain, like any other organ system, and there's damage that occurs that creates a disease. And there's complicated disease. It's like diabetes in a way. You think about diabetes. The pancreas is where the insulin comes from. Well, people in diabetes either have insulin that's not working well or they're not making enough insulin. So what happens is they develop a disease of diabetes. And we have treatments for that, depending upon the individual, some of which would be maybe just losing weight or changing your diet, exercising. Great. But some people need additional help with their diabetes. Maybe they'll take a pill, a metformin, for example. It's a very common pill you can take for diabetes. But some people actually need insulin. They need something stronger. So what we'll give them is the injections of insulin. And some people can get better. Some people need insulin all their life because of the disease state. Well, addiction is honestly no different than diabetes or any other condition. And if we look at it in terms of it being a medical illness with, behavioral, psychological, social ramifications, but if we understand it to be a medical illness and then we understand the treatments for it, then we can start to really make some cures or really make people able to manage it better. And then a lot of the problems we have with addiction, especially opioid addiction, and the overdoses and the deaths that we see, they get better like any other disease state. So what I would like to come from this radio show today is that people walk away from this with an understanding that, hey, there's hope for this. There are medications, there are treatments for this condition. They actually work, and we need to have people have access to these treatments, not barriers, not stigmatization. But these are human beings that are valued, they're loved, they're our family members. We want to keep them alive. We want to get them the treatment they need because these are lives that can be saved. These are lives that can be turned around. These are people that can contribute to society, and then they have what they deserve. They deserve a chance at life. So that's the point I want to make, and I'm so happy to be here. And I think you have some questions for me, and I would be happy to try to answer them.
All right, Gene.
Oh, Dr. Murphy, one of the issues that's been in the past, I think it's been a tradition. I'm not an expert at addictive medicine, but as someone who's on Suboxone, probably going to have to stay on it the rest of their life, just like you said about diabetes. Is it okay that somebody's on Suboxone who also has some other psychiatric illnesses like severe depression or anxiety to add other drugs to their regimen, and they can take Suboxone with, say, for example, Wellbutrin or some other psych drug?
Well, the answer is they absolutely can take Suboxone with other medications. Suboxone is FDA approved for the treatment of opioid use disorder or opioid addiction, or maybe just we can also call it problem opioid use. So that's a condition where the opioid is the issue. The opioid, the narcotic, if you will, when somebody ingests it, however, it goes to the brain, and in that individual, maybe because of their genetics or because of something else or because of the repeated exposure to that drug, they now have changes that have occurred in that deep part of their brain that's subconscious that controls our behaviors. It has various names, one of which is the limbic system, for example. And there are true anatomical structures there that get damaged. And so when that disease process of addiction occurs, it's in that area of the brain, and you can use Suboxone, which is kind of like a combination drug. It has not only the antidote to opioids, which is naloxone. We've heard of Narcan before, so that's in the combination medicine. But Suboxone also has the main ingredient, which is buprenorphine. Now, buprenorphine is a long word, but it really is pretty safe, kind of a cousin to the opioid. It's not a full opioid. It's not like Percocet or morphine or heroin or methadone or any of the other opioids. It's kind of a partial opioid. And so what it does is it can go into you ingest it, goes to that part of the brain that we know is diseased or damaged, and it occupies the receptors there. And it allows the brain then, which you can say the brain's on fire, allows the brain to calm down, and those cravings go away. And some of the physical side effects of withdrawal, we heard about being dope sick. those side effects go away because those receptors in the brain are getting partially occupied and treated by the Suboxone, which is so much safer than morphine or these other things. So they're getting treatment in the area that's damaged and not getting high, not trading one addiction for another. They're getting treated with a medication that's safe and allows their brain to kind of recover. And then if their brain can recover and they can now think more clearly, then maybe they can do the other things they need to do. Maybe they can do job training or take care of their family or go to work or actually just take care of themselves or make good decisions about their health care and their life. That's what's you. It takes away some of those cravings, some of those issues that control it. It treats that part of the brain that controls our behaviors and allows people to act more normal and get on that road to recovery, which could be a long road, usually is, but it allows them to go in that direction. And we know it's incredibly effective. We have statistics on this, research and studies that show that it is highly effective. We know that it lowers the mortality, the death rate from opioid use disorder by over 50%, and in some studies up to 70%. Now think about that. We have an opioid crisis. We have a medication that can lower the death rate by 70%. Well, this is great. Well, what's the problem here? The problem is only 1 out of 10 people in this country that could benefit from this medication ever get access to it. Let that sink in for a minute. I just told you we have this crisis. We have a medication that treats it, but no one can get access to it. That's a problem.
Can you explain to us a little bit about the problem with access in the state of Kentucky?
Okay, well, Kentucky is not unique amongst other states in the sense that people don't understand addiction, and we think about it as being a moral issue or why just say no. Just say no. Well, it's more than people can't just say no. And some people, like I said, with diabetes, need that medical treatment to get to where they can get better. And so we need to educate people that it is a disease state and there's treatment for it and they need to be treated. Secondly, there's a lot of stigma. I mean, let's face it. I mean, people that are suffering from addiction are not always the kind of people you kind of want in your doctor's office waiting room hanging around, If they're, it's hard. They're a tough population and not everybody wants to treat them. We got to get over that, okay, because they deserve treatment and they can be treated. I can tell you as somebody who treats addiction, it's one of the most rewarding aspects of medicine I've ever had. You can simply, very easily, it's not that hard, change somebody's life just by giving them access, just to the medication alone. But the thing is, we have that. And there's also, Kentucky's one of the few states in the nation, incredibly, we're the seventh, we have the 7th highest overdose rate in the country. And we're one of only 7 states that has a regulation that's so restrictive that tells our doctors, you cannot prescribe Suboxone unless you do this and this and this and this and this. And by the way, if you don't do this and this and this and this, we might take your license away from you. As a doctor, who first of all, not quite sure they want to treat addiction, what incentive do I have to put myself at risk, my whole practice, perhaps even my freedom? I might go to jail if I violate a regulation that, by the way, is very onerous. A regulation, by the way, that the American Society of Addiction Medicine, the group that actually created the specialty of addiction medicine, they say there should be no state regulations that are more restrictive than what the government already says. And by the way, buprenorphine is a Schedule III drug, so there are some federal regulations about it. I mean, it's not something you just kind of give out like, candy. There are regulations, but the states, Kentucky in particular, is very onerous and out-of-date regulation that becomes a very big barrier to people getting this medication. That needs to change.
Be specific about what those particular regulations are that the physician has to go through in order to abide by whatever the rules are about giving this.
Well, for example, if a patient comes to you and they're ready to try this, And I tell you what, it's hard to get somebody who's in the throes of addiction to the point where they are ready to do something about it. It's just difficult. But when they are at that moment, when they are ready, you need to get them started on that medication right then and there. It's almost an emergency. If they don't get started on it right then and there, then they might go out and they might, you can't say, well, come back. I'm going to draw some labs on you. We know that people that inject medications have a risk of hepatitis and HIV, things of that nature. And it's good to get those tests done. But if I make that a prerequisite, even a pregnancy test, some people don't want to take pregnancy tests for some reason. But if I require all of these things before I start you on the medication, if I as a doctor feel like it's going to benefit you, but I can't start you on this because I don't have labs back or whatever, then you might go out that night and you might use that night and you might die that night because you injected heroin again. And I had the chance to save you. So we have to be able to initiate medication when we see the patient, when we at that moment. And the regulations basically will not let us do that unless we do several different things like, get old records, labs, things of that nature. Look at the prescription database that Kentucky has. So many things. Get a drug screen, for example, and then make them come back in 7 days. What if they can't get back in 7 days? What if they don't have transportation? Do I take them off the medication? What if somebody is pregnant and we know that Suboxone is like the gold standard now for treating people that are pregnant that have addiction to opioids? The babies do well. People do very, very well on this medication when they're pregnant. Have to refer you to a specialist in order to keep you on Suboxone. Otherwise, I lose my license. Then I'm not going to prescribe it for a pregnant person. And number two, that after 90 days or so, when I have to get the consult with the specialist, patient doesn't come back. I have to take them off the medication. I'm harming them. So I think in the interest of trying to be helpful, these regulations have taken what might be good recommendations, or this is a good idea, and made them hard and fast rules. Whereas if you don't do these things, you lose your license. And that scares doctors. That's not how medicine should be run. Our recommendations in our specialty societies, you all are surgeons. I know you've got guidelines in surgery, and they don't say you must or you shall do things. They say, we recommend, our evidence, our research says this is what we think is the best way to go. But that changes almost every year, what we should do. And regulations should not force doctors to do certain things that we know now are not even helpful to people. Our current regulation is 10 years old. It's 10 years old. It needs to be redone.
Pat, let me make a comment about that. Just the regulations that we have to deal with in Kentucky in the past and more recently with reproductive rights. About 20 years ago, there was a general surgeon that Gene and I both know, I'm not going to mention his name, who had some sight issues, and he retired and ran for public office and became a member of the House of Representatives for a district in eastern Louisville. He gave a talk at the Louisville Surgical Society about 18 or 20 years ago, and there were two things that I took away from that. Number one is the usual issue about making laws is like making sausage. And the other thing he said, and he was very clear about this, and that speaks to your issues with these regulations, as the politicians do not understand health care. They run construction companies, grocery businesses, they're lawyers, and we see this today with the reproductive rights issues, where the laws in Kentucky essentially require that an obstetrician, a gynecologist, dealing with a woman that has complications of pregnancy will have to essentially carry out medical malpractice. I'm not going to go on a rant about this anymore. Gene, do you have another question?
Let me just finish your statement. It's not just malpractice. It's you can be arrested and charged with a criminal offense as the law exists
if
right
you
now.
don't conduct yourself as what is essentially a form of medical malpractice. Yeah.
Right.
It's crazy.
Well, it's different than malpractice. It's a criminal offense. You can go
Yes.
to prison. Let me just proceed with this discussion about prescription for Suboxone. Do you think that any doctor who has a narcotics license should be able to go ahead and prescribe Suboxone who patients that they feel need it?
Well, I'm glad you brought that up because it used to be that you couldn't do that. That you had to ask specifically the DEA to give you a little extra waiver. They called it. They called it the X waiver. There's an X that goes in front of your DEA license. So the doctors had to ask the DEA if they could prescribe this, and they had to do 8 hours of training, which you could get online. But you made an application, and then if you got the application, you could initially treat 30 patients. This started in the year 2000. There was a law called the Drug Abuse Treatment Act of 2000, and that allowed doctors to prescribe Suboxone from their office. And first you could do 30, and then they said, this is good. This is a good medicine. Then you could do 100, and then they said, this is a really good medicine. Let the nurse practitioners do it. Let other people do it. So then they opened it up to other people. Then they said, hey, why all this education? It's really easy to do. Let's go ahead and let people do it emergently do it without the education. It's so important. And they added that to it. And then they increased it to 275. And then in December of 2022, a tree fell in the woods, and I don't think anybody heard it. A big tree. The DEA eliminated the X waiver. And they sent letters to every doctor with a DEA license and said, there's no longer any extra waiver necessary. This is the DEA, we want Suboxone to be available to anybody who needs it. And we no longer have a waiver. You can treat as many as you want, and any doctor with a DEA license can do it with no special training. That's huge. And they did that because there's so much evidence that it's safe and effective. It's no longer the scary drug or whatever that we're thinking of. It is definitely not methadone, which is also very effective, but methadone's a more powerful drug that really is only treats addiction out of a certified addiction method. Suboxone has been proven to be so safe and so effective and so needed that now any doctor with a DEA license can do it, and they are encouraged to do it. They are encouraged by the DEA, by the American Society of Addiction Medicine. They are encouraged by the Substance Abuse and Mental Health Services of the United States. Everyone's on board with this except Kentucky. And we have the 7th highest overdose rate in the country, and it's still record levels, and it's disproportionately affecting our Black population. Do you know that last year we had a tiny drop in the overall overdose rate? I think we're coming out of COVID, and I think Narcan is the antidote's being more distributed. But guess which population did not have a decrease in overdose deaths? The Black population in Kentucky. It went up. And we have data also from the studies from the American Medical Association that says that if a Black person goes to a doctor's office, they are 77% less likely to get a prescription for buprenorphine than a white person. So we have disparities, especially in this field, that are first of all, the stigma. I told you only 1 in 10 people that need this medicine get it, and our traditionally marginalized communities, and in particular in Kentucky, the Black community is suffering in a disproportional manner to this disease, and they and we all need better access to this medication. That's the call for help. That's the call to action that we have.
So how does the legislature need to change the law so that we can effectively treat these drug addicts?
Well, we have a law in Kentucky that covers all of the controlled substances, including buprenorphine. Now that the DEA has effectively said buprenorphine is no different than any other Schedule III opioid. No different. Federally, it's no different at all. Why does Kentucky have a separate regulation for Suboxone? They shouldn't. That X waiver's been gone for almost 2 years. Do you know that our regulation in Kentucky still says a doctor must have an X waiver to prescribe? It doesn't exist anymore. You can't get one. So technically, no doctor can prescribe in Kentucky because nobody has an X waiver. So it's just so outdated. And the American Society of Addiction Medicine, again, the group that created the specialty of addiction medicine, they're on record. They say states should not regulate Suboxone beyond what the federal government does. In other words, we shouldn't have a state regulation on Suboxone. We already got one that governs all of the controlled substances. It came out with House Bill 1 in 2012. That's fine. Let that be the regulation. Why single this out? When you single out a drug like that for addiction, that stigmatizes patients that are on the medication. Why do we have a separate regulation? Why do we have to do all of these things? Why don't diabetic people? Why don't high blood pressure people? Why don't other people have to do these things? Why is addiction such a bad thing that we have to do this to treat it? And secondly, it stigmatizes the doctors that prescribe it and makes them fearful of prescribing. That's why this waiver's been gone for 2 years almost, and the number of prescribers have not gone up. In fact, in Barron County, which was one of the counties that doesn't have one of the counties in Kentucky that we looked at data from. In Barron County, the overdose death rate did not go down in 2023. That was one of the counties where it did not go down. And why is that? They have no prescribers for buprenorphine at the largest clinic in that county, which is TJ Sampson. They have nobody that prescribes it. They have a couple people, nurse practitioners in town. I called down there the other day. They referred me to them. I said, I'm Dr. Murphy. I'm from Louisville. I want to refer somebody. If I did, do you all do that? No, we don't do it there. We need doctors in all of these counties willing to prescribe this. They need to feel comfortable prescribing it. And they need to do it because we have a crisis in this state that it's unimaginable, the number of people that die every year. We have 2,000 people that overdose and die every year in this state. And we have a medicine that will fix that. And we have a regulation that's getting in our way. So it needs to be gone. The regulation doesn't need to be reformed. It needs to be eliminated. It needs to be eliminated. We have a public health emergency. The public health emergency in this country that was started in 2017 was declared, the opioid crisis was declared a national public health emergency. Sound familiar? Kind of like COVID? Okay. Well, COVID's gone. COVID has been taken off the public health emergency list. Guess what has not been? We still have opioid crisis as our nation's public health emergency. So we need to take action. We need to take specific action and strong action, like we did during COVID, doing things to help people. One of which would be in Kentucky, eliminate that regulation. Which, by the way, I don't think there's a law that made this that anybody had to do it. I'm not sure why they did it. There's no law that I know of that said we had to have a Suboxone regulation. I think they just did it because they were trying to help, I guess. I assume that they're all trying to help, and we want to get the word out that it's not helping. It's actually harming. So,
well Pat, I don't see any of this changing anytime soon. The way that redistricting has gone on in Kentucky, we have the same issues with the legislature, with gun violence and reproductive rights. Let me tell you
how it could change, though.
All right.
Because during COVID, there is, if we default to the House Bill 1, there is a clause in that regulation for controlled substances that says during times of emergencies, these don't apply. The governor could say, this is a public health emergency, and this regulation does not apply because it's a public health emergency. He could, with a stroke of a pen, just like he did during COVID, he could make that regulation ineffective while there's a public health emergency. He could do it today.
Well, I hope it happens. Let me change the subject just a little bit.
Can I ask one question about the opioid epidemic?
Oh, sure.
I've thought about this a lot, and it seems as though that the opioid epidemic really started with overprescribing of MS Contin. At least that was one of the biggest issues. And the attorney generals and the government went after the pharmaceuticals. I'm not criticizing them for that. I think that was proper. But one of the things that, in my opinion, they didn't look at was this concept that pain is a vital sign. And as you remember, in the late 90s, early 20s, we were extremely had our arm twisted that we got to treat pain as a vital sign, and I think we got into this habit of over-treating
well, that was
pain.
the pharmaceutical industry.
Yeah, but
getting it to use the drug.
Yeah, but it didn't start. Pain is a vital sign started with the Joint Commission. You remember the signs in the emergency room?
Oh, yeah, well.
And pain's a vital sign, and every nurse had to put in a computerized record how much pain the patient was having.
But if I remember correctly, that was initiated by the pharmaceutical industry. That's where it came from.
I thought it came from the Joint Commission.
Well, I understand that, but I think the initially the instigation for it was the pharmaceutical industry.
Well, who of us is right, Dr. Murphy?
Okay, well, you're all kind of right. But here's what happened. The pain is the fifth vital sign actually came from the president of the American Academy of Pain Medicine, and it was about 1997 or so. And I think it was grew out of a movement that pain was so undertreated that we need to take pain seriously. People with chronic pain were sorely undertreated. And that was an age where new drugs were coming out, like OxyContin, like the morphine you mentioned, extended release medicines, new medications to treat pain that seemed to be more effective. And the thought was that, why, if we have a medication that it's okay to treat in cancer patients, nobody would argue with you that patient with dying of cancer shouldn't have all of their pain treated. But somebody with really bad pain that wasn't cancer related, like multiple back surgeries or lupus or rheumatoid arthritis, they're suffering too. Why are they any different? Why shouldn't they get treated also? So this real patient rights sort of movement came about, and the American Academy of Pain Medicine was championing patients getting proper pain care, one of which was opioids, but there's other ways to treat pain too. And they said, take pain seriously. I'll tell you what, we're going to call it the fifth vital sign. You've got blood pressure, respirations, heart rate, temperature. Hey, we've got a fifth one. Call it pain. That means you have to ask people what their pain score is. The problem is there's no painometer. There's no thermometer for pain. There's no blood pressure thing for pain. Pain's what somebody says it is. I mean, you might be sitting there, Dr. Flynn, you're a tough person. You might, have terrible pain and say, mine's a 2 because you're tough, or because just who you are. And that's your score, your personal score. But Gene, you might be somebody who's more sensitive to things. And you might say, no, I'm miserable. My pain's a 9. Well, you're both right, because it's whatever it is to you. So the thing is, that I think that's a noble idea to say take pain seriously. But the pharmaceutical companies said, hey, we're selling these medications. We're going to make money off this. If we make people treat pain based on these scores, hey, we're gonna do well here. So they actually got in with the Joint Commission, which certifies hospitals, and said, "You got to take pain seriously." And the Joint Commission said, "Yeah, if you don't take pain seriously, a hospital, we are going to take you off our list. You can't see Medicare patients." Well, you can't exist as a hospital if you don't see Medicare patients. So then the Joint Commission told the hospitals, "You'd better treat pain effectively." the pain is the vital sign movement got forward. And then the marketing came out. And you better treat pain. If you don't treat pain, you're not being compassionate. And then it just, once that happened, and once the FDA actually said OxyContin is less addictive than other opioids, and if you have a drug that is less addictive and it's effective and can treat pain, people are suffering, why, as a doctor who's compassionate, why would you not give them everything they needed to treat that pain? And so the push was out there, and it was, the marketing was so intense. And to this day, I think they've put numerous doctors, many doctors, hundreds of doctors behind bars who were just trying to help people. But I don't think a single drug company executive or anybody at the FDA has ever lost their job or spent one day in jail for what they did to this country. But the doctors that try to prescribe and help people, just there's many of them in prison right now. So, I mean, that's kind of how we got to that point. And honestly, if we have trends in medicine, and I think we probably overprescribed in the late 90s and early part of this century, but I think the doctors would have figured it out. What happened was this movement got hijacked by the greatest, most expensive, far-reaching marketing ploy or marketing campaign ever in the history of medicine, and that was with the opioid, the Purdue, all of the drug companies marketing medications, saying that they were less addictive than they really were.
As Sackler family got off free.
Well, no, they paid some money.
Well, they paid some money, but nobody took responsibility.
No.
Well,
no,
Pat,
no.
I want to. We want to run out of time here eventually. I'd like to move on to. I want to make some comments about fentanyl, and then I want to get your views about what I've said or what I've said that may or may not be correct. Number one, it seems to be a major killer today of the users, and my understanding is that as a result of some political negotiations, the drug fentanyl is not shipped to Mexico from China, but the ingredients that you put together to make fentanyl is sent from China to the cartels in Mexico, and they're literally shoveling this stuff together in garages and barns and places like that, mixing it with other street drugs, and that it's killing people. And it's my understanding, if you have a pill that has fentanyl in it and you try to test it for fentanyl, you could test one side of it where there is no fentanyl, and you could test the other side, there was enough fentanyl in there to kill you. Now, I'm going to let you comment on that. I have very limited knowledge about this, but that was my understanding of what's going on with fentanyl today, which is a major killer of users in not just in Kentucky, in this entire country.
Yes, fentanyl is a killer, but fentanyl is also probably the most prescribed drug in surgery. It's one of the best analgesics that we have for people having surgery. In the right hands, used the right way, it is a godsend.
Yes.
And it helps people. And there are also patches that people that have chronic pain can use, that they can put a patch on their skin and just get a small amount of it delivered through their skin over a period of 24 hours. And it's for those people, it can be very safe and very effective, used the right way. However, like you said, when these pills from the street are counterfeit and they're adulterated, and somebody might think they're buying a Percocet, for example, and they're getting a Percocet laced with fentanyl, it's extremely dangerous because it's an incredibly potent medication. In some respects, it's 100 times more potent than morphine, and it's driving the death rate now. In fact, statistics say about 75% or so of all overdose deaths now are fentanyl related. So you've hit upon the big problem. It's not prescription That's gone down about 50% in the last 10 years. The number of pills prescribed. We got the message in medicine, and we're not prescribing like we used to. It's the doctors have adjusted there. But what has happened is that the disease of addiction, the demand for this, mind-altering drug has not gone away. And so we need to treat in this country, we need to treat this as a public health crisis, and we need to educate people on multiple levels. We have to start with harm reduction. People that are already addicted and might be using this medication, keep them alive. If they need Narcan to keep them alive, keep them alive. Give them food, give them some place to live, keep these people alive so that they might get into treatment. And people that are kept alive through harm reduction services like that are at least 5 times more likely to enter into effective treatment later on than somebody else. So that's what we have to do as the foundation. Then we have to offer real treatment to people that have addiction. And that would be things like, have psychosocial services available for them. Because addiction is a biological, psychological, and social issue with these people. But we also have to make sure they have access to these medications for opioid use disorder that we know are effective. And there are 2 of them out there that are incredibly effective. It's buprenorphine, that's the Suboxone, and the methadone clinics. And there's another one called Vivitrol, which is that's the trade name. It's an injectable form of naloxone, which kind of blocks some of the receptors and prevents people from relapsing, or helps. It's not foolproof, but it helps prevent people from relapsing. That's like a once a month injection. So you've got ways of addressing this. Some of these can, they cost some money sometimes. Yeah, but the return on your investment for these harm reduction services and these treatments for opioid use disorder, it's like you get like 10 times your investment back on this in terms of how much you're saving the public. It's amazing.
So give us an overview of where we are today with, I guess, just drug use issues compared to 5 or 10 years ago. Is it getting better, getting worse, or about the same? It sounds to me, from when I read about it and what I've been looking up, in anticipation of talking with you about on this program, it's getting worse.
It has gotten worse. It was actually, if you look at this, the statistics, it really started like in the 60s, and it started with actually when they had this war on drugs started, and maybe 60s and 70s, and back then it wasn't necessarily the opioids; it was crack, cocaine, and things of that nature. And you heard about crackheads and crack babies and everything. And then as that kind of addressed, and they thought of it more of an urban male problem or whatever, black urban male problem, if you will. So that's where the stigmatization came, and the over incarceration of people where they actually had health problems. We can get into that. That was tragic what we've done to a whole population of people that should not have been stigmatized like that. But the addiction rate started rising then, and then it became driven by heroin, and then it became driven by the prescription drugs, and now it is driven by fentanyl, and it has gone up and up and up and up. And then what happened with COVID was such a socially disruptive time where people were stressed out and whatever. We had big jumps during COVID, and in Kentucky, it was already hitting record numbers, but when COVID started, it increased another 50% in the first year, just boom to a record number. And so we have not really come down in the last 2 to 3 years from that. It bumped up about 50% in the overdose rate in this state. It has stayed there, except in the black population, it's actually gotten worse, as I said. So no, we're not winning this. We're learning more about how to approach it. But what we're doing now is not working. It maybe we're treading water a little bit. It's not working. So we have to treat this on all fronts with harm reduction, with prevention, with effective treatment, and then with follow-up with people that are in recovery. Give them the resources they need to stay healthy. So, and we can do that. We have a pathway. We know, we have evidence. We know that it works. We need the resources, the people to allow us to do it. And the resources will return dividends. That investment gives you return of investment of up to 10 times what you invest in this.
Now, the resources are health care coverage. Is that correct?
Yeah, that's one of
because
the major ones. Access to health care.
A good friend of mine works, retired ER physician with the homeless population here in Louisville, and he's told me that, 1/3 of the homeless population are people who have drug problems, and most of those do not have access to health care. So my question was, could you give us an overview of the percentage of Medicare, Medicaid, private insurance, no insurance, just so we have a sense of what what their access is. And I have a follow-up question after you answered that.
Okay, now I don't think I can give you really good statistics on that. I can tell you from experience, though, that a lot of the people that we had served through the Kentucky Harm Reduction Coalition, that many of which live on the street, they've come for some help. We try to get them access to health care when they meet us at the various sites that we provide services, and we can actually get them hooked up at times. Get them hooked up with Medicaid, and get them appointments at the University of Louisville. People that accept Medicaid, and so if you're, I think a lot of people don't have the means to go and get hooked, get signed up. So there's a process that people are left out because they have not had somebody help them get signed up. I think that there's its availability. There's a lot of people that don't have the income, or they qualify for Medicaid, can get it, but they don't have access to it. There's also a large group in the middle after that have some type of insurance, but they have high deductibles, or they don't cover Suboxone. They have to have pre-authorizations, for example, and they then just don't go get it. So that's a barrier as well. This is a disease process where people have to be able to be engaged in the healthcare system the moment they decide they are ready to try it. And these barriers, like not having access to insurance coverage, or not having access to the other healthcare that they need, or even paying for the medication, through insurance. If they don't have access to some sort of means to do that, you lose them. They go away. They say thanks. They take their Narcan. Thank you. And then they don't get the health care that they need. You hope they come back sometime, but too many times they don't, and that's tragic. The insurance issue is a huge barrier.
All right, my follow-up question is that, first of all, this program is sponsored by a local group called Kentuckians for Single Payer, and we're promoting Medicare for all. Just suppose that if we had Medicare for all, how would that affect the access to care, and how would that, what impact would that have on the population of drug users, or the addiction population?
Well, I think that having available immediate access to health care is the answer. I'm not sure exactly the ins and outs of what Medicare would mean, because I think that even Medicare can be complicated. I think that there should be a level of healthcare in this country where anybody who needs it can walk up to a clinic and say, I'm here, I need healthcare, and they can get it without any worry about, at least some level of acceptable healthcare, without having to worry about the cost at that point. I think that is aside whether it's a human right or the compassionate thing to do, I think that makes our country stronger and healthier. It's the right path to take. But whether Medicare is the answer, I'm not the expert to answer that. I can tell you that we need to have something that is really easy for somebody who needs healthcare to get. I can't tell you how many times people put off things because they're afraid that it's going to ruin them financially. That's an issue as well. Not just not having any funds, but people that say, I can't go get healthcare because I can't afford the deductibles. It's going to ruin me financially. So they let it slide. And that's the wrong thing to do.
We have
we need
100 million people in this country with a medical debt. 100 million.
crazy.
Jill?
I
Jill?
mean,
I
I'll take.
want to get back on the fentanyl issue. As you know, in this presidential election, the border is a big issue, regardless of which side you're on. Is there, if we do pass legislation for the border, is there any way that anything we can do to stop the fentanyl coming across the border into the country and creating this phenomenal problem?
I don't basically think we're going to be able. I think they'll find a way as long as there is a demand for it. And I think it's a supply and demand issue. I think the best way to combat this, obviously, you want to get the criminals at the border, do what you can, do everything you can. It's really hard to do that. But I think we need to work on the demand side of the equation and treat this disease of addiction that we have, treat it effectively. And then if the demand goes down, then there won't be the need for this fentanyl to come across.
Do you get the Courier Journal?
Yes, I do it. I don't subscribe. I get it off and on.
Okay, well, I've got a Sunday, July 14th edition of the Courier Journal, and there's an article in there about how the cartels have moved into the small towns in Alaska.
Yeah, I saw that.
You saw that? How much time we got?
Let me just make a comment about dealing with a cartel.
3 or 4 minutes.
Most people don't know this, but we had actually had drug interdiction in Colombia during the cocaine problem. So much cocaine was coming from Colombia, and we actually had active duty military in there. I found this out one day. I was taking an Uber trip, and the driver was retired military, and I asked him where he spent most of his active duty, and he said Colombia. They were doing drug interdiction. And we were also involved in the 70s in the same thing in Bolivia. I was involved or flying along with C-130 that was taking supplies in to the drug interdiction people in the jungles of Bolivia. So I think that we're going to have to get involved with the Mexican government and in order to try to stop this, although the cartel may be bigger and more powerful than the Mexican government.
Yeah, Pat, we're getting down to the end of the lollipop here. I want to give you an opportunity to make whatever comments you'd like to make before Paul takes us out.
Okay, thank you. Again, thank you for allowing me this opportunity, this platform to come on here. And and I want to just dovetail or with that last comment you made about the cartels and how do we stop this. That is a supply and demand issue. And I think that the difficult from me to give you advice on how to stop the supply, that's for the DEA and those experts, but I can tell you that we need to work on the demand side of it. We need to treat this disease of addiction as though it were a public health crisis. I mean, like we did COVID, we need to get after this and be serious about it. We have medications that work for it. We have treatments that work for this. We got to start with prevention, harm reduction, treatment, and then supporting people that are in recovery. Prevention, harm reduction, treatment, and support people in recovery. If we do those things, then the demand side will drop off and the cartels will have to find some other place to send their drugs to.
Well, Pat, listen, thank you again. It was a great program. All
safe,
right, listen, stay well and stay safe out there.
You all too. Thank you very much.
Thank you for what you do, and thank you for what you're trying to do at the KMA.
I appreciate that. Thank you, sir.
Thank you, Doctors Mike Flynn, Gene Shively, and their special guest, Dr. Pat Murphy, on this very educational program on a very important subject. Stemming the tide of this opioid addiction crisis in Kentucky and the nation is something I feel very strongly about. I plan on posting a synopsis of this program on our website in the very near future with some thoughts on what we all can do to help the situation. Look for it on kyhealthcare.org. Before we go, I'd like to mention that the upcoming Give for Good Louisville, the Most Generous Day of Giving, hosted by the Community Foundation of Louisville, will be back on Thursday, September 12th from midnight to 11:59 p.m. Give for Good Louisville isn't just a day for online donations, it's a time that sparks kindness across all ages and unites communities for the greater good. Since its launch in 2014, communities across Louisville and southern Indiana have raised over $60 million for local organizations. The organizations that benefit from Give for Good Louisville reflect our community's values by addressing unmet needs, creating innovative solutions, and proactively driving positive changes. Leading up to the big day, we encourage you to support your favorite causes, including Forward Radio, and explore new ones, making a difference in Kentuckiana. Help us stay independent, commercial-free, local, and vital to the community by supporting us during this important fundraiser. You can find out more by visiting forwardradio.org. This is Paul Hoppe for Single Player Radio. Have a good rest of your day, and goodbye.